So the common theme of all those other conditions was that we had a very clear indication, and there wasn't a lot of debate about whether or not the patient had the condition, i.e. H. pylori, bleeding, use of NSAIDs. Those are things you can't argue with. But what about the off-label use for reflux disease in infants and young children who cannot necessarily verbalize what they're experiencing? And we have to rely on subjective reporting from parents and caregivers. So this is ultimately the dilemma that we face, and this is really why the indications in infants and young children are being put under the spotlight as of late. So to help open this up, I'm going to present a quick case, and this is a 4-month girl that you see in an outpatient setting, possibly for a routine checkup, but the parents bring up that they're quite concerned about her acid reflux. And I put that in quotations. We'll talk about why that is in a second. So the reason they're concerned is that she spits up 1/2 to 1 ounce 6 times a day, often associated with the appearance of discomfort by their report. She's been crying or fussing more often than usual as of late, often within an hour after feeding. So again, they attribute this relationship to feeds-related symptoms and possibly reflux. And she also has lots of hiccups, and she arches her back frequently. However, she's thriving. She's not stopping her feeding. She's not refusing any feeds because of these perceived symptoms, and she has not had any symptoms suggestive of stopping breathing or apnea or cyanosis where she turns blue. And based on all of these symptoms reported, she would actually qualify as having more significant symptoms concerning for reflux disease. And for clarification, the most recent guidelines in pediatrics define gastroesophageal reflux disease to be distinguished from gastroesophageal reflux as being present when the reflux of gastric contents is the cause of troublesome symptoms and/or complications, which is a very easy thing to define in a sentence, but very hard to practically apply to the pediatric population, much less the infant population, because as we'll see, the issue of causation is always going to be in question, as well as the determination of whether or not these symptoms are troublesome. So this was the original title of the presentation that was requested of me, but when I realized that it could be answered in one slide, I broadened the topic. So the obvious answer to this question is yes, because of the simple fact that in infants, there are no approved uses of PPIs in this age group in Canada or in the United States, really. And more recently, the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition have come out with a statement suggesting that the use in infants should be significantly restricted, and particularly when the question is of unexplained symptoms of irritability and crying without clear evidence of it being related to gastroesophageal reflux disease. So looking at this slide, however, this represents a review of PPI prescription claims on commercial healthcare plans in the United States from 1999 to 2004 and shows an alarming trend. Here you see that the estimated prevalence of PPI use in infancy increased 7-fold between 1999 and 2004 to just under 0.5%. So unless there was some sort of epidemic of reflux disease in infants in those latter years of the study, the implication is that something else was going on. And I do believe that the statement from the North American Society was in part in response to this study and was trying to communicate the simple message that not all infants who cry have reflux disease, and not all infants who have reflux or regurgitation require the use of a PPI. Irony of this all is that the pediatric gastroenterologists as a group themselves were probably as guilty of prescribing these medications for technically unapproved indications than any other group. As you can see, pediatricians and pediatric gastroenterology or gastroenterology staff composed just under 90% of all prescriptions, and only 2% of prescriptions were made by general practitioners. I don't show it on the slide, but of the infants who received a PPI, about half of them were less than 4 months old. So as we'll get to in a bit of a roundabout way, the reason why PPI use is generally discouraged in infants and young children is because there are several studies that show that relying on symptoms alone as an indication to treat patients in this age group with PPIs does not result in an improvement in symptoms. And here's a graphic representation of why these studies probably do not show a benefit. And so here you see all of the potential ways that gastroesophageal reflux disease may manifest, so with symptoms or complications. And as you can see, there are extraesophageal and esophageal-related concerns. And not all of these apply to the presentation in infants and young children, however. So for example, the symptomatic syndromes that you see there. And then you start to get a sense of the reason why grouping all these patients together and then studying them and saying that PPIs are ineffective is probably not the best strategy. Because if you look at the symptoms that are purported to be due to reflux disease, they are often classic symptoms that we would potentially see in older children or even up to adulthood. However, they are very nonspecific and very hard to prove that they, again, causality from reflux disease. And the same goes for the possible associations with extraesophageal symptoms that are often related to the respiratory tract or the airway. So the take-home message here is that the reason why the PPIs are overused in infants is because the large majority of symptoms that may or may not be associated with reflux disease are very hard to prove based on history. And that should also give you some insight as to why the trials that we'll talk about at the very end have not shown any benefit for these patients as a large group. So there's really 2 points here. One is that regurgitation is extremely common in infants who have reflux disease or in infants who do not have reflux disease. So regurgitation alone is not sufficient for a diagnosis of reflux disease, i.e. troublesome symptoms. So infant may regurgitate quite frequently, but it may not be a problem to the infant. It may be concerning for the parents, but that does not necessarily mean that the infant is actually bothered by it. So here is a result of a study that was done prospectively and showed that 41% peak prevalence of infants around the age of 3 to 4 months who spilled or regurgitated with most feeds. So not just with a single feed, with most feeds in a day, so 41%. And of course, that does taper over time, but you can see why in young infants it becomes more of an issue. We also have several studies that show that parents are more likely to be concerned about reflux or to consider it a problem when the frequency of overt regurgitation, i.e. regurgitation out of the mouth, bringing food out, is increased. So while it is a characteristic symptom, it is not sufficient for a diagnosis of gastroesophageal reflux disease. However, it can fool us, and we are probably still more likely to treat reflux that is non-pathologic at this age on the basis of overt regurgitation as opposed to seeing these symptoms in an older individual. But the other problem is that, and this is likely the age where the PPIs are going to be the least helpful, and why is that? In this group, they found that up to 85% of reflux was non-acidic, and this was in 50 infants evaluated for reflux, and over 1,800 events to look at. But while the evidence is not necessarily conclusive, there is definite theoretical plausibility for this, and in young infants who are feeding more frequently, the milk can act as a buffer to the gastric acid. And that's supported by another study that showed that the proportion of non-acid reflux, so reflux that was not acidic, decreased with age, so as infants got older and perhaps were feeding less frequently, as well as the time elapsed from the meal. So the more closer these events were to a meal, the more likely it was non-acidic, which makes sense because that would mean that the contents of the stomach were a mixture of both gastric acid and the feed itself. So this goes to show that the use of a PPI, which really its main job is to reduce the acidity of the stomach, may not be that beneficial to these patients, and also suggests the possibility of reflux-related symptoms that do not actually have anything to do with the acidity of the contents. So hopefully this picture will also help explain the 2 main features that I was talking about. So one is the complexity of making the diagnosis, and 2 is the possibility that the reflux-related events may not be related to the reflux of acidic contents. So if we took this blue box and represented everything within there, represents all the cases of irritability and crying in infants who also are known to regurgitate. So the first possibility is that the regurgitation actually is related to reflux and is related to the irritability and crying. But that alone can be due to a variety of different factors. So one could be true erosive esophagitis, where you have damage to the esophagus endoscopically when you look because of the acidic contents or other elements of the contents causing chemical irritation. This would only be detected with endoscopy. Then you have a group who have non-erosive reflux disease, and this term was used in adults and it is more controversial to be used in a group like infants, but I put it there just to describe the group who, if you did an impedance study, would show significant number of reflux events, which are either acidic or non-acidic, and of these events, so if you checked it with symptoms and correlated, you would see an association between the crying and irritability and reflux events. There's then a group that wouldn't actually have pathologic reflux disease based on an impedance study, so that wouldn't have a significant number of events or prolonged time exposed to acidity. However, that every time they had a symptom, you would see a strong association between the symptom of crying and irritability and reflux, and that can be either at the reflux of acidic contents or the reflux of non-acidic contents, or both. And again, in adulthood, this has been termed as hypersensitive esophagus, and may be related to the acidic reflux or non-acidic reflux. And then there's finally a group that you may actually see an association between them on an impedance study, but they actually wouldn't be considered reflux disease because it is not caused by the reflux itself. So an example would be the simple fact that if you're crying excessively, you are more likely to generate negative intrathoracic pressures and therefore favor a pressure gradient for promoting reflux of contents in the stomach towards the thorax or into the esophagus. So you can see alone how complex that part is, and the fact that you may not be able to detect any of these entities unless you do an impedance test or endoscopy. And what I've tried to show there is starting the conditions where treatment with a PPI will actually be beneficial, and you can see not even all those cases will respond to a PPI, nor should they. We also don't know what percentage of cases are actually related to reflux. So for example, what I mean is you may have an infant who cries a lot, regurgitates a lot, and the crying and irritability may not be related in any way, shape, or form to the reflux. The baby could have infantile colic and regurgitate. The baby could actually have true vomiting and not have regurgitation, and the vomiting may be due to many reasons. So they could have an infection, they could have some sort of gastrointestinal disease that is unrelated. So for example, celiac disease in an infant older than 6 who's just introduced to gluten, or they could have an anatomic obstruction in the GI tract, or they could have a central nervous system disorder, metabolic condition, endocrine disorder, problem with the kidneys. So you can see the variety of different causes. And among those, what makes things even more complicated is that there could be a gastrointestinal condition associated with both reflux and discomfort. So for example, constipation may make you more likely to have discomfort in and of itself, but it also may predispose you to reflux because of delayed gastric emptying as a result of the constipation. Cystic fibrosis, a condition where you may have discomfort for other reasons, has a high rate of reflux associated with it. Allergic disease and delayed gastric emptying in and of itself. So hopefully from all that you can see that there are conditions that infants and young children who have reflux disease may present with irritability and crying in association with regurgitation and may benefit from the use of a PPI. And then but there's probably a much larger group that will not respond to a PPI, either because they don't have reflux, so how can we identify these patients? And as you're going to see, the results of this are a bit depressing because we don't really have a great way to do that. So obviously the thing that we rely the most on is the reporting of symptoms by the caregiver. And symptom-based diagnosis of gastroesophageal reflux disease remains problematic. I don't have time in this talk to go through the even more complicated issue of the association of extraesophageal symptoms with reflux disease, but the bottom line is that all of those symptoms I listed could plausibly be explained by reflux disease. However, there's no proof of causality or exacerbation in all of the different studies in pediatrics that have been done, and particularly in otherwise healthy infants. Esophageal symptoms lack sensitivity and specificity, and then you have another problem. So for example, even something like regurgitation, which is very clear-cut, is neither necessary nor sufficient for the diagnosis of gastroesophageal reflux disease at any age. but particularly a problem again in young infants who regurgitate a lot. So is there any way to help with these symptoms individually, which we rely upon? And the answer is there probably is some benefit to the use of more objective questionnaires that have been validated and may improve the sensitivity and specificity of symptom reporting. And the other advantage of these is that they can be completed by the caregiver, and they can be done ahead of time, for example, in the waiting room, and then you can review these data and then clarify points with the family. Some of the older questionnaires that were validated took up to 20 minutes to complete, so I didn't list those examples here, but two of the ones that recently have been studied and shown to have some evidence behind them would be the I-GERO-R, or the Infantile Gastroesophageal Reflux Questionnaire revised form, as well as the GSQ-I and GSQ-YC, which stands for Gastroesophageal Reflux Symptom Questionnaire for Infants. Looking at one of those specifically, the I-GERO-R was recently studied and developed from the initial I-GERO, or the Infant Gastroesophageal Reflux Questionnaire, that was developed several years back, and they basically found 12 questions which were thought to contribute to the determination of whether or not the reflux symptoms were troublesome. And all of the questions start with the line, during the past week, did the baby ... And as you can see, there are 3 questions relating to regurgitation, 2 questions regarding feed refusals or stoppages, and 3 regarding the features and characteristics of the crying, 1 about hiccups, 1 about arching back, and 2 about apnea and cyanosis. One thing you'll see here quickly is that the symptoms actually range in severity. So apnea and cyanosis, while only contributing a certain component to the score, I would consider much more troublesome or problematic than some of the other ones. And from that study, they determined that a cutoff score of 16 out of 42, which is the maximum score, could be used to help distinguish a group of infants who would be more likely to have a reflux disease. And that case that I gave it initially, that patient would have scored a 23, so would have been significant, and was actually the median score in patients who were determined to have reflux disease in that study. So symptoms, okay, so those may not be as helpful, but again, we have some ways to maybe improve the way that we ask about symptoms. So how about investigations? So surely those could be helpful in infants. Well, what the bottom line here in this slide is that the investigations in infants for reflux disease are invasive, and just like in adults, have significant limitations to them. So starting with the 24-hour esophageal impedance probe, which is often done with a pH probe, again, detecting any episode of reflux of liquid contents. So the problem is that the studies have shown that the findings on these studies do not predict injury or complications, but they can be useful for proving an association with symptoms. Not causality, but an association. So in an ideal world, we could take every patient who has has question of reflux with significant unexplained irritability and crying, and we would subject them to an impedance study, pH study. But of course, that's not practical, and so please don't take that as a message from this presentation that this should be done for all patients, but it can be done certainly for situations where there is doubt. Endoscopy is more useful as when you're assessing for other etiologies of the patient's crying, unexplained irritability, for which there may be a gastrointestinal disease that's contributing. And this was from the North American Society's review, considered some of the warning symptoms potentially related to the gastrointestinal tract that potentially warrant a workup in endoscopy. So vomiting, but not just vomiting, vomiting that was considered consistently forceful because reflux can sometimes trigger an episode of vomiting. Bilious vomiting because of concerns for anatomic obstruction. Undigested food, which would consider mostly for things like rumination, which can be seen in infants. Nocturnal reflux or vomiting, which again is not a hard or fast thing and needs to be considered based on the age. And then finally, the onset greater than 6 months of age, because that goes into the natural history of reflux and regurgitation, which, as you saw, tend to decrease with time after the age of 4 to 5 months, not increase. Gastrointestinal bleeding is listed because, of course, that is always a concerning symptom for inflammation or damage to the mucosa. Failure to thrive, because the suggestion there would be that there could be malabsorption, but sometimes failure to thrive, of course, can be due to a host of other reasons, and not only that, it can be due to poor intake, which sometimes, again, may be related to reflux disease. Diarrhea, because of the reasons of potential malabsorption. Constipation was listed, but again, that needs to be taken with a grain of salt, so not everyone with constipation and regurgitation is in trouble, but I think that's also meant to include the group of infants who are less than 6 months who have severe constipation, and you're worried about an underlying dysmotility, obstruction as a condition such as Hirschsprung disease. And finally, the other warning symptoms are actually related more to potential underlying causes that have no relationship to the GI tract, so, but more to CNS disorder, so central nervous system, genetic or metabolic causes such as hepatosplenomegaly, macromicrocephaly, so big or large head, bulging fontanelle, lethargy, or fever. So that if the symptoms can't be necessarily relied upon and the investigations aren't necessarily helpful, so then how about the old Empiric trial, which is probably the number one reason, if I had to guess, why PPIs are used in infants or young children, which is the fact that we really just can't tell whether or not they're a candidate to respond to PPIs. Well, the advantage of it, of course, is that you don't need to subject them to investigations. They don't need to go to various visits to find this out. It's either they're going to respond or they're not going to respond, and that seems like it makes a lot of sense. And again, in some cases it may, and we'll talk about that in a second. But the one thing to consider when you're doing that is that the natural history of both crying and regurgitation can overlap, and both are usually trending towards near universal resolution of symptoms over time. So what I mean by that is crying tends to peak at around 3 to 4 months of age, and then tends to decline over time in infants, and that's a part of the normal spectrum of behavior that we see. Whereas regurgitation, as we showed, has a very similar curve and will also start to improve over time. And to maybe highlight this, and again, this is a bit of an interpretation, but it's a worthwhile study to look at, is a assessment of the use of pantoprazole in infants for symptomatic gastroesophageal reflux disease between the ages of 1 and 11 months. So these were patients who were determined to have significant troublesome symptoms based on a symptom scoring, much like some of the questionnaires that I kind of discussed. And these patients were all put on first for 4 weeks of the OL, or the open label trial, where they all received pantoprazole. And as you can see, the mean change from baseline was towards an improvement in symptoms over time. So these are the symptom scores. They decreased by an average of 2 points by 4 weeks in both groups, and that was statistically significant. However, then after that, they randomized patients to receive either a placebo or to continue on with the pantoprazole. And you see here that in the first week after withdrawal of the PPI in the group that received placebo, their symptoms were higher relative to the group that continued on pantoprazole, so you can see that here. That may be due to rebound symptoms after having been on a PPI for a while, which we'll talk about later. However, over time, you see here that the two curves start to become equal. And that does raise the question as to whether or not these patients were going to improve over time anyways because of their age and the fact that they were getting older and they were more likely to be less irritable over time, and that perhaps the medication actually had no benefit whatsoever. So in particular, the symptoms of regurgitation and unexplained crying and irritability in infants are probably not sufficient alone to warrant a PPI. In fact, most would argue that you should not use it in this indication, and there is actually evidence to prove that. And again, I think that is because that you were taking that whole group within that blue box that I had drawn out, and you're expecting a significant improvement in that whole group, whereas you're really only going to see a small subset of that group where PPI use will actually be beneficial. And this was a systematic review that came out just last year, looking at trials on the basis of a common outcome of issues related to crying fussiness. And you see here that the study actually, the outcomes were too heterogeneous to pool the data, but they put them out here in sort of something that would resemble a box plot to show you that in literally every study, there was no significant difference between the groups that received a PPI or a placebo in improvement in these symptoms. And so while the quality of evidence in a lot of these studies is lower, there is certainly insufficient evidence. So I don't want to leave people with the impression that PPIs should never be used for the treatment of suspected gastroesophageal reflux disease in infants and young children, but I do want to leave them with the concerns and general advice. So first I'm going to start with the NASPGHAN guidelines, which I don't list here, but that's the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And their guidelines really suggest that, and they emphasize that you need to have just cause for the treatment in this group, and even so, it should be time limited, and you should even consider at this point having an assessment by a pediatric gastroenterologist. Now, I'm not saying that every patient who you're considering the use of PPIs needs to necessarily be seen by a gastroenterologist, but you need to at least have that thought in your mind. And in particular, when the patient's not responding to a PPI and there's still some concerning troubling symptoms. The other point that NASPGHAN makes is that you should not use it for regurgitation or unexplained irritability and crying alone if you believe that the crying and irritability is within the normal spectrum of behavior for an infant of that age. So now I'm going to talk about the NICE guidance, and again, this is also based on expert opinion out of the United Kingdom, and they suggest that either a PPI, proton pump inhibitor, or an H2 receptor antagonist, so those are things like ranitidine, could be used for infants or young children with reflux esophagitis on endoscopy, which is an obvious indication for us, but again, not necessarily approved by Health Canada or for the most part by the FDA, but for the simple reason that we know that it will help and can be used for time-limited trial. And then they talk about the child with persistent heartburn, retrosternal or epigastric pain at any age who's able to verbalize this. And again, as we talked about briefly at the beginning, anyone under the age of 8 or sometimes up to 11 may not be that reliable in reporting, and that's why, again, they talk about using a time-limited trial to see if there's any benefit. And they say reassess at 4 weeks and then consider a referral if there's an incomplete response or the symptoms recur after stopping treatment. I also wanted to include this other opinion by Dr. Hassal, who put this out in a very nice commentary that was entitled Overprescription of Acid-Suppressing Medications in Infants, How It Came About, Why It's Wrong, and What to Do About It. And I highly recommend it. It's a very nice commentary. But in it, he leaves the reader with a couple suggestions for this challenging population. So he suggests that in infants with inconsolable, protracted crying, arching or screaming, and rejection of the bottle or the breast, who are suspected to have gastroesophageal reflux disease as a cause of these symptoms, he suggests that any treatment should begin with explanation and reassurance. So this would include behavioral pediatric concepts such as the normal patterns of crying in infants, when they tend to peak, when it's considered abnormal, and the wide range of normal behavior and that you might see in infants. Reassurance that it's very possible that that could be the case, that the unexplained issues may be actually not related to reflux, and also reassurance that nothing severe is likely to happen under your watch when you continue to observe them over time, and if it is, then they will act on it. He then suggests a 4 to 6 week period of non-pharmacologic strategies, and these start with dietary modifications, which do have some evidence, albeit again not of the highest quality, but do have some evidence for use in infants with suspected GERD. And these include things such as some of the suggestions that were trialed in the study by Ornstein et al. In 2008, and those include thickening of the feeds with rice cereal in patients of a certain age, who are receiving formula, frequent feeds with limited volumes per feed, depending on the age, again, if they're formula fed, so that it would be 4 to 8 times a day, depending on the age, with a goal of 120 kilocalories per kilogram per day. It would also include the removal of dietary allergens in patients who are either breastfed or formula fed. So if they were breastfed, they would suggest the mom would do a removal of soy or milk from their diet for, again, a time-limited trial, or extensive hydrolyzed formula or hypoallergenic formula in the case of a baby who's formula fed. And this, again, would be time limited because of the possibility and association between allergy in a subset of infants with reflux and unexplained crying. Positioning has been suggested. Now, we know that reflux tends to be limited in patients who are prone in infancy. However, we also know that this is not an appropriate recommendation for sleeping, but what this could mean is that the patient should be observed in a prone position after any feed that's possible when they're awake. And it also means to avoid any supine positioning or sitting whenever it is safe to do so, for example, when they're not in a car seat or in a bed. Lastly, in that study, they recommended tobacco avoidance, which is a simple measure, but of course is good for the health of both the patient and also a general health recommendation for those in the house who use tobacco. And then Dr. Harsell also includes a suggestion to do some calming, non-nutritive soothing maneuvers such as rocking, patting in a rhythmic fashion, for example, 2 to 3 times a second in a quiet environment, or something like a car ride. And very interesting as a strategy because, again, using those 4 to 6 weeks may help you determine if the natural history of the symptoms was going to be improvement in and of itself because of the aging and increased relative maturity of these patients. And it also gives you an opportunity to see if some of the non-pharmacologic strategies were helpful that may point you more towards reflux or colic, for example. The only issue I take with this strategy is that you are doing multiple things at once, so if there's improvement, again, you're not really sure which one is the cause, so it might be more beneficial to do some of these things in a stepwise fashion over the 6 weeks that you're going to be following them. And then at the end of all that, he says that if they still are having symptoms that could be related to reflux disease and are still troublesome, then in that case, it would be reasonable to do an empirical 2-week trial of acid-suppressing agent. And there he recommends the use of an H2 receptor antagonist. He says then if there's no response after 2 weeks, that it's unlikely to be reflux disease. But if there's an incomplete response because of the possibility that PPIs may have a plausible mechanism as to why they may work better, it might be appropriate to then try a 2-week period of a proton pump inhibitor before abandoning it. So in summary, there's a small subset of fussy infants with gastroesophageal reflux disease, so true disease, but presenting symptoms are often common and nonspecific. Questionnaires may help, but they are far from perfect. The use of impedance and endoscopy are invasive, and they have their limitations, but they also have their uses. So with respect to impedance, to use it for association with symptoms when there's a strong diagnostic dilemma and something like an empiric trial would be inconclusive, or sometimes considering it before even going ahead with an empiric trial of a PPI or an H2 receptor blocker. And in the case of endoscopy, to use to rule out other potential conditions they may present with vomiting or severe regurgitation that are actually not related to simple gastroesophageal reflux disease. And finally, the empiric trial, the diagnostic and therapeutic challenge, can be reserved for a small subset after a period of counseling and observation, and with any of these things, it has to be time limited. There is equally weak or non-existent evidence for H2 receptor antagonists or PPIs for the treatment of gastroesophageal reflux disease or suspected disease in infants and young children who are nonverbal. If there is a good response, then you have to think that it could be due to reflux disease, but you also need to consider the fact that they may have gotten better on their own, consider that natural history, and also consider the placebo effect. And if there's an incomplete response, you really need to rethink the diagnosis of it truly being a refractory gastroesophageal reflux disease, because that's less likely to be the case. But if you are on an H2 receptor blocker to start. Again, a PPI trial could be okay, but really at that point you should rethink your diagnosis.